So I'm going to tell you about my dipyridamole tale, things that have happened with me over a number of years with dipyridamole. Just before I say that, more than 30% of drugs that we use are not given for their registered application with Pharmac or with MedSafe. So many drugs we are using out of the actual registered area. So here we go, my dipyridamole tale. I told you about I was a rural practitioner and then an urban practitioner. Can I just say the top picture here is of Dargaville, the upside down river in the northern Wairoa. This is where I began. I told you this morning that I'd been a medical registrar and had thought that I'd go on and become a consultant. But I gave general practice a go for a year and I remained in general practice ever since. This gentleman who you see up here on the left was my mentor, probably more like a father figure for 17 years of my life, really. Morris Matic was the son of a Croatian gum digger. His father was a fish vendor in the northern Wairoa, and Morris was a larger than life character. Maoris thought he was a tohunga. He became involved in local politics, regional politics, and at one time was the chair of the Medical Association. But Morris was larger in life and other things. I put a picture here of B12. Someone earlier on in the program over the months before had put me down to speak about methylation. And thank you, Tracy, for your talk on methylation. But Morris, before people were talking about giving me 12, gave B12 to anyone who was tired. Before John Snow talked about Tapanui flu, before Cheney and Pedersen with the Lake Tahoe outbreak of chronic fatigue, he was giving B12. I didn't know why he gave it in the beginning, and he didn't really know either, and he didn't know about the methylation pathway either. I mean, we now know that B12 in chronic fatigue is not absorbed very well across the CFS membrane. So Morris was enthusiastic about many things. He liked to give new drugs, and dipyridamole came on the scene in the 80s, and it was one of the top 50 medications, not just in the US, but in New Zealand. And Morris was into giving dipyridamole. A couple of patients I saw that he had seen, he'd put on dipyridamole, and I could not understand why he had given it. There didn't seem to be a vascular reason. And we covered the hospital on weekends in Dargaville. And one day I went in, and he was one of these patients who he had put on dipyridamole that I had a chat with, who in fact had had a stroke. But I learned that he had actually stopped the dipyridamole, probably because of what I had said to him. So ever since then, it's been etched into my brain. And you know what happens with negative emotion and medicine, it doesn't go away. It's there for the rest of your life. So just about dipyridamole, we know that it's an antithrombotic agent. It has an effect on platelets. It decreases the phosphodiesterase enzyme, which then has an effect to actually increase cyclic AMP here. So it inhibits that. It also has an effect to increase locally adenosine. So dipyridamole has this action of inhibiting platelet activation and aggregation. It also has the action of being a vasodilator and improves the endothelial-derived nitric oxide. This was a problem in some people. Some people didn't like this when we gave it in the early days. And it also has antioxidant properties as well on vascular membranes and LDL. You know that it's used in the secondary prevention of stroke, non-cardioembolic TIAs and CVAs. It was never really given much by itself. Aspirin was given with it. It was found to be of more benefit, and largely has been superseded by clopidogrel. Just remember that clopidogrel is very similar, so is ticagrelor, but these have a different action to the dipyridamole. I mean, they do have an action on the P2Y receptor. Remember that clopidogrel is a prodrug, and a lot of people don't realize that it fails in about 14% of people, largely in Polynesian and Pacifica. I don't worry about it too much in my practice because I'm in the hospital up here, gives it, but probably if you're Polynesian or Maori and you're given it, it may not work. We don't do a genetic test on it. Just remember though that digabantrin and rivaroxaban are not acting on platelets. they're acting on the clotting system. We've heard already about cancer. It's not the prime cancer that kills people in the majority of people, it's the metastases. So here, mentioned many years ago in 2011. To do with cancer spread, the circulating tumor cells, platelets, are the protective shield that allow these little creatures to go around your body. So when platelets are surrounding it, then the natural killer cells cannot actually go in and kill off the actual tumor cells. The platelets also facilitate their adhesion to the endothelium, and they also trigger the transforming growth factors in NF-kappa B pathways, which allow it to go across from the inside of the vascular membrane into the body itself. Now, for decades, I have got this magazine. If you're interested in what's happening on the edge of medicine, you would read the Townsend Letter. The Townsend Letter, as it says here, is the Examiner of Alternative Medicine. I find it informative. I know what's happening. Often the things that I have seen for the last 30 plus years, over about 10, 20 years, are now becoming mainline. This gentleman here on the right, Wayne Martin, would regularly write to the correspondence column of the Townsend Letter. He was a contributor for years, a brilliant chemical engineer holding worldwide patents in copper, aluminium, and magnesium alloys. As a teenager, he had lost a leg. His mother had pernicious anemia. He fed her a pound of liver a day before we even knew anything about B12. He had a very inquiring mind the whole of his life, especially in the areas of cancer and heart disease. So this is the letter that he wrote, and here you'll see this is in September 2002. He wrote it at 91. I'm not sure that I'm going to be practicing at 91, but I admire this person. I hope I've got the same alert mind. So he writes this letter in September of 2002, and he mentions in the beginning, he's talking about this Dr. Rhodes and her colleagues at the St Helier and Kingsman Hospital in Surrey, and this is in the Lancet, March 23rd. These doctors for the past 11 years have maintaining melanoma patients with these at level 4 and level 3 with dipyridamole. They gave 300 milligrams a day. There were 30 of them altogether. There were 26 who were level 4, and the 4 others were level 3. Their 5-year survival rate for level 4 patients was 74%. The 5-year survival for the total of the 30 of the 11, 4 and 3, he said, was 77%. None of the 11, 3 patients had died. The expected life survival for level 4 melanoma is 32%. Can I just say, when I looked up what the American Cancer Society says about the survival for stage 4 melanoma, they say it's 20%. And 100% of the deaths with melanoma are by spread of the disease. Then he goes on down the bottom. Dipyridamole tends to prevent the attachment of cancer cells flowing in the blood circulation to the endothelium, and thus tends to prevent formation of metastases. He goes on. I've had a long exchange with Dr. Betty Rose, who has been in retirement for about 8 years. She's treated melanoma with dipyridamole because she's a dermatologist, and that is the kind of cancer that she has treated. She has been disappointed that there has been no follow-up on this most hopeful indication that she has demonstrated of dipyridamole in treating melanoma. She feels that dipyridamole may be just as effective in treating many other forms of solid cancers. He then goes on to mention the anti-cancer effect of dipyridamole may be due to other things, and he talks here about a Dr. Eva Bastida, who writes in the Cancer Research Journal in 1985 that the inhibition of certain human cancer cell growths by dipyridamole. Dipyridamole causes an inhibition of greater than 80% of adenosine, thymidine, and uridine. These are substances needed by the cancer cells to prosper. This may indicate an anti-cancer effect of dipyridamole other than in preventing metastases. And just a wee something about dipyridamole. Dipyridamole here is 2 pyrimidine molecules, and pyrimidine molecule is the nitrogenous base that makes up the nucleotides. So it has an effect on DNA. He goes on, March 1999, there is now new light thrown on the harm of platelet aggregation, this time with respect to cancer. And then he mentions this study in 1999 from Regensburg, Germany, using 3 different tumor lines in mice. It was demonstrated that the tumor cells can activate platelet aggregation, and that platelet aggregation deactivates cytotoxic natural killer cells, preventing the NK cells from killing cancer. He then comments, it's cheap. Why aren't we using it for the treatment in broad spectrum of cancers? In 2012, shortly after this, I came upon this book, Beyond the Magic Bullet, the Anti-Cancer Cocktail, by Raymond Chang. He's an oncologist, and he's also a pioneer of complementary and alternative medicine. Researcher at the Sloan Kettering Institute for 10 years, and then he went out into private practice. And in this book, Chang outlines a rational and practical cocktail strategy that simultaneously employs multiple drugs from different categories with different biological mechanisms. Non-drugs such as herbs, vitamins, supplements, and other so-called alternative treatments are included. And so he says, monotherapy or simple regimes and single modalities applied sequentially until they fail is not an optimal strategy. A complete rethinking of our approach to cancer treatment is needed. An advanced cocktail strategy has the potential to revolutionize cancer therapy. So in the book, for about 3 or 4 pages, he talks about dipyridamole. I'm just going to quickly go through these. 1987, not just the effect on stroke and heart, but decreased the cancer mortality by 30% in the population. They discovered that dipyridamole also had an effect to increase the effectiveness of chemotherapy. And this was also seen by Japanese researchers too. He goes on to tell about the severe advanced pancreatic cancers, 39% response rate amongst pancreatic cancers who were treated with chemotherapy and dipyridamole, and 1-year survival rate of 70%. Remarkably, 27% of these cancers who initially had inoperable cancer were able to undergo surgery. The 1-year survival amongst this group was 83%. Then the Japanese did the same thing, except they did better. They got 83% response rate, and 60% of the patients were able to undergo curative surgery. Now, Tim mentioned Jane McClellan this morning. I find her a most fascinating person. So I'm just going to spend a few moments talking about her. So in September 2018, she wrote this book, which Tim showed, How to Starve Cancer Without Starving Yourself, the discovery of a metabolic cocktail that could transform the lives of millions. In 1994, as a 30-year-old, she was diagnosed with aggressive cervical cancer, had a hysterectomy. Just to say about the cancer, it was a bit like the National Women's thing. It was overlooked. The gynecologist didn't do anything. It was totally ignored. Had a hysterectomy, had pelvic spread, and this was followed by chemotherapy. 4 years later, she developed a nagging cough, and she was found to have lung metastatic spread, so she was up to grade 4. And at that stage, she says to herself, there's been so many cock-ups, I think I better start to become the expert for myself. So she began to search the literature. I think you should know she's a very clever physiotherapist. She topped her class, and she knew how to go through a library and find out all this information. So she did. She wanted to know what caused the cancer and how she could do something to inhibit her own cancer. And like Chang, she came to the conclusion too that cancer, or advanced cancer certainly, is a complex disease requiring a complex solution. The problem was that in 2003, she ended up with myelodysplasia and went on to early leukemia. And she understood well then that this was probably the consequence of chemo. She also thought that viral infections had played their part. But at that stage, when she's at that moment, she comes across Wayne Martin. And so this, I've written here in the bottom here, this is in chapter 10, Walking on Eggshells. She says, his letter describes dipyridamole, an antiplatelet drug for cardiovascular problems, and how its anti-cancer effects have been ignored. It became clear that here was a powerful anti-cancer drug that had direct effects on blood. I felt a shiver of excitement as I read on. Was dipyridamole going to rescue me? So let's just go through some other things. So she became aware, well, she knew that her myelodysplasia and her leukemia probably had a connection with viruses and to do with oncogene change. Dipyridamole in 1977 here was found not, this is in vitro experiments, was found not only, we knew it was a vasodilator, but it has an effect to inhibit viruses. And you'll see down the bottom here that it inhibits many viruses, rhinoviruses, influenza, coronaviruses, mumps, measles, herpes, pox viruses, and even chlamydia. McClellan became she was aware of this paper in 1988, where this is to do with HIV, that dipyridamole potentiates the effect of AZT against human deficiency virus type 1. And going on here, these findings suggest the possibility of using dipyridamole or its analogues in combination with chemotherapy for HIV infections. I came across this paper a couple of years ago to do with dipyridamole as a new treatment, possibly to prevent Epstein-Barr virus reactivation. And this was another in vitro experiment where Burkitt cell lymphoma lines with Epstein-Barr were put up against dipyridamole. Dipyridamole inhibits Epstein-Barr virus reactivation from B cell lines. Dipyridamole repressed immediately early gene expression, mostly through its ability to inhibit nucleoside uptake. And then they go on, consider its wide clinical use. Dipyridamole repurposing could shortly be evaluated alone or in combination with other antivirals or treated in Epstein-Barr virus-related diseases. And I wonder about that in chronic fatigue. The pharyngeal cancers are all EBV-related diseases too. And now going on to COVID, this paper came out in March of 2020. This was a blinded trial of the 31 patients here that were, these were severely ill patients. Of the 31 patients, only half received dipyridamole. And they showed that in the patients who got the dipyridamole, they had decreased concentrations of D-dimer, increased lymphocyte and platelet recovery in the circulation, and markedly improved clinical outcomes in comparison to control patients. 8 of the dipyridamole treated severely ill patients showed remarkable improvement. I made a note after this morning's talk where someone asked a question about the COVID vaccine and what you could do. There is a controversial doctor in Canada called Charles Hoof, who has spoken out strongly against the Moderna vaccine, where he found that people didn't do too well. In those cases, he did D-dimers, and he found them to be raised in 62% of people, and the authorities didn't like to hear about that. But maybe even in the vaccinated community, it may go on and do things to coagulation. It certainly does in the disease. Now, what did McClellan do? Well, this is one thing she did. She knew that, and you'll see in this little diagram here, she knew that cancer cells need cholesterol for growth, just like our cells do. If you can stop the cholesterol, maybe you can stop the cell from growing. So this is the study that came out in 2014, that if you could do something to the melaninate pathway and stop the synthesis of cholesterol, you could actually cause apoptosis. So this study was where they showed that they gave statins, and in conjunction, they did dipyridamole down the bottom here, which in fact has on the sterol regulating element binding protein, which is to do with the actual gene synthesis of the actual pathway, that you could actually block cholesterol synthesis and lead to cell death. What did Jane do? Well, she did many things. She did add dipyridamole, she did add lovastatin, she did take aspirin, she did take an anti-inflammatory drug. She took Edelac, which is a bit like Clinaril, which now I see Pharmac have removed, or MedSafe have removed. We can't prescribe it now. This morning, Tim mentioned Celebrex. And now at age 57, obviously many years later, she is alive and well. She still continues to take a whole lot of things, a whole cocktail of things. I don't want to talk about her 5 hallmarks of cancer. Can I just say though, all the nibs and nabs that are being talked about now are to do with abnormal cell signaling pathways here, and also to do with what we see in abnormal growth factors. This is where they are. Just a wee thing here I talked to you about with naltrexone. This is toll-like receptor 4 and 9. So in some cancers, that might have an action as well. Dipyridamole has an action across this, actually. It has an action on many things. One thing that I found really interesting, one thing she tells the patients who inquire with her what to do, she tells them to go and find out what their metabolic phenotype is of their cancer. If you take a cancer and put in a search for metabolic phenotype, you will get whole lots of information. You will be overcome. I read her book, the back part of her book, which is all the theoretical stuff and how she came to this, decide on these things. It took me probably 3 times to understand what she was getting at. You should also obviously integrate whatever you do with the best of oncology. She does not advocate people going alone. I think you do it with the best of all evidence-based cancer therapies. Informed consent becomes important here again, especially when you're dealing with a drug that's an off-label drug. You obviously need to make sure that the patient understands what they want to do and what I'm going to do. So I ask them to read this this is what I've written, off-label medication in cancer. I get them to read that. I get them to sign a consent form too, that they've read this and they understand what they do. I do not push people into cancer therapies. If people come and ask me, I will tell them what I think. I do not bring it up, as I'm busy enough without dealing with people with advanced cancer. It's hard work, as Damien said this morning. Obviously, if they're not my patients, I have to tell their doctor, and I have a template here that I use. So the take-home message is this: dipyridamole is more than an anti-thrombotic vascular agent. It does prevent embolic cancer spread. It does seem to inhibit RNA and DNA nucleotide synthesis. It has a synergistic action with chemo drugs and statins. It has antiviral action. I think we should be looking at advanced cocktail strategies when we talk about treating cancer. I think monotherapy or one drug after another is not enough. Tim has mentioned the Care Oncology Clinic. Can I say, my understanding of Jane McClellan is that she predates this. She has been a catalyst for this clinic and other clinics to begin. She's embarrassed traditional oncologists. And if you do a search now, even on Amazon, you'll find there are academic books coming out now on the same area of oncological treatment. Don't buy her first book, buy her second edition, which has just come out, and always remember about informed consent. Now, I've thrown this in about metformin. Tim mentioned metformin today. This is, I read Medscape. I read lots of things. This came out about 2 weeks ago. This is a study from Iceland to say that in a population where, in fact, they gave people metformin, those who, in fact, who had basal cell carcinoma were a lot less than those who in fact took the metformin. So my challenge to you, I see lots of people with basal cell cancer. Am I going to give the worst ones metformin? So there's a challenge. What are you going to do with that information? So that's all from me, my dipyridamole tale. Thank you very much.